Oh, okay. Are we live? Really? No, no. Oh, really? Yeah. Yeah. Well, it's like, huh? What? Yeah, I'm close. Brett.
All right, guys, let's go ahead and get started. All right, well, let me go ahead and get things started. Thank you, everyone, for joining us today. It is my honor to introduce Dr. Nasir Khatri for today's Insight Grand Rounds. Dr. Khatri is a double board certified anesthesiologist and interventional pain medicine specialist here at Insight. He's renowned for his expertise in advanced pain medicine techniques. He adopts a holistic approach to patient care, emphasizing multidisciplinary strategies for healthy mind and body. Dr. Khatri's academic journey began at North Carolina State University, where he graduated as valedictorian. He then excelled at VCU School of Medicine, finishing at the top of his class and being inducted into the prestigious Alpha Omega Alpha Honor Society. His residency was at UNC Chapel Hill, that's where Michael Jordan went, Tar Heels, and it was marked by significant involvement in research and leadership, and he further honed his skills with fellowship in interventional pain medicine at University of Kansas. Before joining Insight, Dr. Khatri contributed largely to a significantly large health system in North Carolina. He implemented advanced interventional pain procedures. He is nationally recognized for his leadership in pain medicine and serves as co-chair of the Young Innovators within American Society of Pain and Neuroscience. Additionally, he consults for medical device companies, reviews for medical journals, speaks for national conferences, and has authored numerous peer-reviewed studies and guidelines. Outside his professional and amazing endeavors, Dr. Khatri enjoys spending quality time with his family, reading, history, running, traveling. So without further ado, please join me in giving him a warm welcome.
All right, well, good afternoon, everyone. Appreciate everyone being here and joining us for this Grand Rounds talk today, and to go over sort of what I really consider to be a very important topic, especially I know that we have a lot of internal medicine physicians here. It's something that comes up a lot in the outpatient management of patients, which is lumbar spinal stenosis, or really just pinched nerves and back. We're going to mostly be talking about the diagnostic workup as well as a lot of those minimally invasive treatment options which exist today. One thing which I didn't realize is I don't have my slides in front of me, so I'm going to grab my laptop if that's okay. And
I know what it's.
all right, perfect. Next slide. Next slide. Perfect. And these are my CME relevant disclosures. Next slide. So the main objective of today is really to define lumbar spinal stenosis and describe the epidemiology of the pathology, or really to discuss how relevant this is in the outpatient world, discuss diagnostic workup, including imaging and physical examination, review minimally invasive treatment options, and then also integrate insights from these national guidelines called the MIST, or the minimally invasive treatment of spinal stenosis guidelines, in the 2.0 version of that. Next slide. So when we discuss lumbar spinal stenosis, it's really a reduction in anatomic size of the spinal canal, the nerve root canals, or the neuroforamen, which leads to buttock and leg pain, plus minus back pain. There's no quantitative criteria for spinal stenosis which has been set, but absolute mid-sagittal diameter of the lumbar spinal canal has been well adopted as a measure of spinal stenosis. Patient-specific history of neurogenic claudication symptoms along with imaging help to improve accuracy of the diagnosis. And it's important to note that spinal stenosis can be primary, as in congenital, or it can be secondary and acquired. And remember that secondary or acquired is far more common, as is the case with a lot of medical conditions, with prevalence estimated at 11% for the general population and as high as 47% in those who are over 60 years of age. Spinal stenosis is the most common reason for spine surgery in patients who are over 65 years of age. Next slide. So when we characterize spinal stenosis, we often do so via imaging, and specifically the gold standard is to look at MRI. When we're looking at MRI, there's three main areas in the spine in which stenosis can be categorized. There's the central canal, and here, reduction in diameter and volume of the thecal sac, either in AP or transverse. An AP diameter of a thecal sac less than 10 millimeters is consistent with lumbar spinal stenosis. And the most common symptoms are neurogenic claudication, also known as pseudoclaudication, which is that kind of aching and heaviness in the back and definitely in the legs, especially when walking and standing, and improved with leaning forward as well as sitting down. Next slide. The red box kind of indicates exactly where I'm talking about when we're discussing these things. So the lateral recess, or also known as the subarticular zone, is the next area of the spine that can be compressed, leading to stenosis. And it's often considered stenotic when the AP measurement is less than 4 millimeters. And due to the proximity to the central canal, stenosis in this region can lead to radicular symptoms with or without neurogenic claudication symptoms. Now, radicular symptoms is that kind of zinging pain in a dermatomal distribution that's kind of going from the back all the way down the legs, again in that classic radicular or dermatomal pattern. And then finally, next slide, we have the neuroforamen. And in the neuroforamen, which is really formed by the interpedicular osseous opening. So it's really an opening in between two bones where the nerve root exits. And stenosis in this region is often multifactorial. It can be due to facet hypertrophy, which is the joints in the low back, as well as bulging discs. Stenosis on imaging is based on a height of less than 15 millimeters and or varying degrees of reduction of perineal fat on sagittal MRI. So I know this is a lot of kind of in-depth information. Suffice it to say that stenosis comes in many different forms: central, lateral recess, and foraminal. And depending on where this quote-unquote pinch of the nerves is, your symptoms are going to be different. Meaning that if the pinch is more centrally located, you're going to have that classic claudicant pattern. If it's more lateral or affecting the nerve root, you're going to have more pain consistent with just sort of one dermatomal distribution. Next slide. And that's what we're kind of discussing here when we're talking about patient-specific history. I often tell, trainees and other, kind of, physicians even who are learning this, that obtaining a specific history is paramount when we're talking about spinal stenosis, because it really tells us how significant the patient's pain is and what we're going to do to treat it. So patient-specific history here would be progressive pain or heaviness radiating to one or both lower extremities in the posterior aspects of the thighs and legs. These symptoms are reproduced by walking, prolonged standing, and lumbar spine extension. Symptoms are improved with sitting down or walking in a flexed position, like a shopping cart sign. Often, we'll see those elderly patients in the grocery store, they're holding onto the shopping cart, kind of lean forward. The reason why they do that is because that actually helps to open up that stenotic segment of the spine. So patients may have concomitant vascular claudication as well, which can cloud the clinical picture, but neurogenic claudication symptoms improve with flexion. And remember that vascular claudication does not improve with flexion, because why would it? Next slide. In order to aid our assessment of these patients and the diagnosis as well, we do use validated assessment tools as well. This includes the Zurich Claudication Questionnaire, Swiss Spinal Stenosis Questionnaire, or the Walking Tolerance Test. All of these are essentially trying to determine whether or not patients have symptoms consistent with neurogenic claudication. Next slide. Now, just as important as history is, of course, a physical examination as well. And over the years, there has been a significant evolution in the way in which we use a physical exam to determine if patients are, suffering from neurogenic claudication. In 1977, Dick and Doyle reported the utilization of a bicycle test in the differentiation of vascular claudication and neurogenic claudication. Because often these patients are in an age category where they're likely going to have both. Spinal stenosis patients had symptom improvement with leaning forward on the bicycle, and that's why now, even probably in some of your guys' internal medicine booklets or questions, they'll ask about this recumbent bicycle that's used to distinguish between vascular claudication and neurogenic claudication. In a recumbent bike, you're leaning forward. When you're leaning forward, as I mentioned before, it opens up the stenotic spinal segment, so your symptoms actually improve, the pain is actually coming from your spine, versus if you're working out your legs and you're increasing the amount of aerobic metabolism that's going on in the muscles of your legs, and there's not enough blood flow, well then your symptoms are not going to get any better. Patients may ambulate with the flexed posture, that's that forward flexion that we discussed, with limited mobility and extension of the lumbar spine. And remember that physical exam findings have positive and negative likelihood of ratio of 1, meaning that the physical examination, unfortunately, is not necessarily our best tool in diagnosing these patients, but it is very helpful in ruling out other pathologies. Next slide. EMG and nerve conduction studies are also utilized in many of these patients. Often these are either normal or they may demonstrate multi-segmental abnormalities. EMGs and nerve conduction studies may be helpful adjuncts to distinguish between lumbar spinal stenosis and radicular symptoms from peripheral neuropathy. Again, remember that, when we read our textbooks in med school or in residency, patients often fit one bucket, right? They fit one category. But then when we see these patients in the hospital or we see them in the clinic, we realize that they suffer from everything, right? And probably just one thing more than another in that moment. This is where all of these adjuncts in our diagnostic tools are very important. Next slide. Radiographic findings, I really think this is one of those moments where imaging really plays a huge role in the management of these patients. So there have been many studies that have shown the superiority of MRI to CT as a standalone modality. Again, the MRI is going to give us far more information about nerves as compared to the CT scan, which gives us relevant information about bony anatomy. There's no single consensus which exists on quantitative assessment for various lumbar spinal stenosis degrees of severity. And actually, when I was going through training, this was the thing that actually kind of surprised me the most. We've been talking about this for decades now, but the radiologists have not been able to come up with one standardized imaging criteria to determine whether or not a patient has spinal stenosis, or if they agree on if someone has spinal stenosis. The grading the severity of it is not always actually fully agreed upon. There is a study by Gao et al. Which suggested that sagittal radiographic analysis alone showed a poor correlation with post-operative outcomes. And so again, making sure that we look at multiple views on the MRI is important. And it's also important to recognize the limitations of diagnostic studies. Next slide. So there's these MISC guidelines, which are these national guidelines for the management of spinal stenosis, and there's multiple consensus points. So we see here that there's a different grade that's given to them, level of certainty based on the amount of evidence and expert opinion, and of course the level of evidence as well. And the guidelines state that the diagnosis of spinal stenosis with neurogenic claudication should be based on a combination of imaging and history, which we discussed. MRI and or CT evaluation in the axial and sagittal planes should be evaluated to enhance the detection of lateral recess and central canal stenosis. Upright hyperlordotic positioning may have a higher detection yield versus conventional spine MRI imaging and could be considered in select symptomatic individuals. And this is actually pointing to the fact that sometimes we don't think about it, and this is something that I kind of urge the internal medicine residents and all of us really to think about, not just for the spine, but often when we get imaging, remember that it's done in one position. So whether that's an upright x-ray or for CT scan when they're laying flat, it's only giving you information when they're in that one specific position, right? So even when you're looking at pleural effusions and things, remember, if they're laying down flat for that CT scan, that's when you see it. That doesn't mean that that's what it looks like when they're standing upright as well. And those are all the things that I think are very important for us to critically think about when we're actually evaluating patients. Scanning flexion extension films with care to evaluate the index level of stenosis detected on advanced imaging are recommended for dynamic instability evaluation. And what this actually means is that there's a condition called spondylolisthesis. And what that means is that there's two vertebral levels which are where the bones are offset from one another. They're not perfectly stacked on top of one another. And when that that malalignment occurs, when you bend forward and bend backwards, that can actually cause a further worsening of the malalignment. That then can actually be an indication for surgery. So getting those flexion extension films is critical. Next slide here. So differential diagnosis. Again, key part of medicine is to determine what other pathologies may exist that mimic this same pathology, and in doing so, perhaps have a different treatment option. So peripheral neuropathies, there exist in up to 8% of patients who are over 55 years of age. The most common is a length-dependent neuropathy in that glove and stocking distribution. EMG and nerve conduction study can be helpful to rule out peripheral neuropathy. And then peripheral neuropathy is painful at rest and during sleep. And remember that neurogenic claudication is actually painful with walking and standing. So this is how you can help determine whether or not, even if a patient may have both, which one is more symptomatic. If they're telling you that their feet are burning at night, that's not necessarily neurogenic claudication, unless it's also accompanied at least with walking and standing pain in the back and legs as well. Next slide. Vascular claudication. That's the question that always comes up because these exist, probably the vast majority of our patients who have neurogenic claudication do have an element of vascular claudication as well. Remember that vascular claudication is a supply-demand mismatch of oxygen consumption during muscular activity, right? So whether that's in the legs or it's in the arms, it's a supply-demand mismatch. Thoracic outlet syndrome, that's on I think on internal medicine exams as well. That is a vascular claudication symptom that occurs in the arms due to a supply-demand mismatch in the upper extremities, right? And so vascular claudication, of course, in the legs is from sort of a buildup of cholesterol and fatty plaques and things like that in the blood vessels of the legs. These symptoms are worse with walking and standing, and they're improved with sitting down. And this recumbent exercise bicycle, again, really is used to help differentiate between neurogenic claudication and vascular claudication as well. Risk factors include atherosclerosis, tobacco use, and type 2 diabetes. And I can guarantee you that your neurogenic claudication patients, as well as your vascular claudication patients, both have these risk factors as well. Next slide. Lumbar radiculopathies. So if you might remember to some of the earlier slides, I said that depending on where the pinch of the nerve is in the spine, it manifests differently in the patient. So for some, the pain is just, this heaviness in the legs when they're walking and standing. That indicates that that pinch is more centrally located along the spinal canal. But if, for example, the pain is, if the symptoms are more kind of in that radicular pattern going down the leg, then this is more consistent with a lumbar radiculopathy and a pinch being more laterally located. And so nerve root impingement and or inflammation, that's lumbar radiculopathy. It's often concomitant with neurogenic claudication due to lumbar spinal stenosis. Patients have a positive straight leg raise. And then nerve conduction study can be used to distinguish between peripheral neuropathy from a radiculopathy as well. And so next slide. The MIST guidelines state that differential diagnosis of symptomatic spinal stenosis patients may include a variety of pathologies, and accurate diagnosis and dynamic stability assessment are essential for long-term treatment benefit. So the key point from here, make sure that you're thinking about other pathologies that could be causing these symptoms and then evaluating for them accordingly. Next slide. So minimally invasive treatment options, looking beyond epidural injections. I think that for the vast majority of the people here, we think about spinal stenosis, we think about back pain, we think about any of these sort of classic back pain symptoms, and we think, oh, just go to the pain doctor and get an epidural injection, right? And so while that is true to a degree, right, there's a lot of new treatment options that exist. And what we found out a lot with these epidural injections is that, one, they actually don't necessarily help us as much in the long term as we think that they did, one. Two, a lot of these patients are elderly patients, and repeated exposure to steroid puts them at significant risk for osteoporosis and other hormonal issues due to repeated steroid exposure. And so really giving them an option beyond steroid injections is very important. Next slide. So we're going to discuss just a few different treatment options which exist now in 2024 and really have sort of developed within the past few years. And the first of these is something called a percutaneous image-guided lumbar decompression, piled, or what you'll see here is mild, which is just a specific branded form of this treatment option. This is actually a clip, and I wonder if we can play it. Hmm?
There's not.
Okay. Well, never mind. Um, I want to show you guys just because. Okay. Well, in this procedure, what we do is that in patients who have central canal stenosis, there is a anatomic, there's a ligament basically called the ligamentum flavum, and that with age actually hypertrophies, and then it causes and contributes to central canal stenosis. So in this procedure, what we do is that through an incision that's about the size of a baby aspirin, we use a variety of different tools to actually cut out a piece of bone, which you actually see in this image here. Yeah, but basically, we cut out a piece of bone, and then through that piece of bone that we've cut out, we introduce another instrument, which then clings on to the ligamentum flavum, and then basically scoops it out. So when the nerves are getting pinched in the center of the spine, through that ligamentum flavum, we actually can debulk that through this procedure, which basically is done through the incision, an incision about the size of a baby aspirin, does not require general anesthesia, same-day procedure, and so again, allows for us to be able to offer these patients who don't have a great surgical option, a treatment option, without having to really subject themselves to long-term rehabilitation afterwards. Next slide. So this was developed in 2005 for cancer patients, actually, who are too high risk for open decompression. And a lot of times what you'll see as you go through your training in internal medicine or any other field is that a lot of times these more novel procedures actually were introduced for patients who were too sick for traditional open surgery. And then as time went on, these patients actually, the treatment actually becomes available for more patients as well. So again, this procedure was developed in 2005 for cancer patients who were too high risk for open decompression, minimally invasive instrumented decompression of the posterior elements, and again, that's that ligamentum flavum. So we're looking here specifically at ligamentum flavum, which is on MRI measured to be greater than 2.5 millimeters. This is an on-label procedure between L1 to S1, and then evidence-based treatment with 2 level 1 RCTs, several level 2 prospective studies, and then 1 5-year retrospective longitudinal observational study as well. Next slide. For this procedure are spinal stenosis due to hypertrophy ligamentum flavum. Again, measuring on that MRI of 2.5 millimeters is key. Neurogenic claudication symptoms, facet hypertrophy and disc disease can be concomitant, but this procedure doesn't treat that. So again, it's really used to treat that central stenosis. Does not mean that they can't have those other types of stenosis as well, but the central canal stenosis is really what it's indicated to treat. And then reduction in spinal canal pressure from debulking posterior elements allows for symptomatic improvement in patients with facet hypertrophy and disc disease causing neurogenic claudication. Next slide. So there are, of course, as with every procedure, there's absolute contraindications and there's relative contraindications as well. Absolute contraindication is a prior spine surgery at the index level, the level that you're treating, which has already been surgically intervened upon. Those same anatomic landmarks that exist for us to be able to do the procedure don't exist anymore. And then, of course, the presence of a localized infection at the site of the procedure would really open the patient up to seeding infection, and that will be quite problematic as well. Now, there's relative contraindications as well. The presence of a higher than grade 2 spondylolisthesis, and that's again that malalignment of the bones on top of one another, a bleeding disorder, and then the presence of a systemic infection. All of those are relative contraindications to this procedure as well. Next slide. I'm not necessarily going to go through each of these studies individually, but what I do want to, let's go back one slide. What I do want to note here for everyone is that, this is the first, this procedure dates back to 2010 when it started, becoming more mainstream in the world of pain medicine. And there's a lot of studies that have kind of prospectively evaluated the safety of this procedure. And so, for example, with Dr. Deere, Dr. Capperell, Dr. Deere is in West Virginia, Dr. Capperell is in North Carolina, they were the first to kind of describe the surgical technique for this procedure to everyday pain physicians. They looked at 90 patients prospectively, and they demonstrated safety with lower complication rate compared to traditional minimally invasive spine surgery. And then Trospo and Caraway, they also did a prospective study as well. Next slide. Dr. Brown specifically looked at this procedure versus epidural steroid injections, and they looked at disability index as well as pain scores, and they followed up through 12 weeks. And what they found was that the pilot procedure was more effective than epidurals in providing symptomatic relief at 12 weeks. And of course, still, this is relatively short follow-up for a procedure that we're saying that is really debulking the posterior elements. And then next slide. What we see here is that Dr. Stotts led the Midas Encore study, which was a huge 302 patient double-blinded study in which patients were compared to getting an epidural injection versus this procedure, and it actually followed these patients out to 1 and 2 years. And what they found was that the decompression procedure was superior to epidural procedures at 1 and 2 year follow-up for all primary outcomes. And then there was no serious device or procedure-related adverse events between both groups. And then next slide. Nagi Mikhail in 2021 published a study. He's out in Cleveland Clinic, and he actually did a retrospective study at 5 years, looking at 75 patients, and he found that only about 12% of those patients progressed to open spinal decompression surgery, and that durable pain relief was found in the majority of these patients, even at 5 years. And he found that, again, that the adverse events related to the procedure itself were similar to an epidural injection. That's why we often tell patients that this procedure is just as safe and effective as or just as safe from a safety profile standpoint as an epidural injection. Next slide. So on the basis of this evidence, one slide before that. On the basis of this evidence, that's where the MIST 2.0 guidelines recommended as a 6th consensus point that this procedure should be considered for the treatment of mild to moderate spinal stenosis in the presence of neurogenic claudication, which with less than or equal to grade 2 spinal listhesis, and with the contribution of spinal narrowing with at least 2.5 millimeters of ligament hypertrophy. All this means is that we should consider this procedure in patients who have mild to moderate stenosis, who are not doing that great with continued epidural injections, where we want to avoid frequent epidural injections with them, and they do have MRI evidence of ligamentum flavum hypertrophy. Next slide. So interspinous spacers, these are devices that are placed in between the spinous process. Again, I wish that these videos were playing because they would show you guys kind of how this procedure is specifically done. And basically with an incision that's about 1 inch long in the back, this device is implanted, which is basically looks like the letter H you can think of. It looks like the letter H, and if you can think back to what the spinous processes look like, or on your back, right, on the vertebrae, it sits in between the spinous processes. And what it does is that it blocks extension. So if we go back and we think about the patient who's at the grocery store, who's leaning forward on a shopping cart, and that helps open up that spinal segment, well, standing upright and extension actually blocks off that spinal segment. So by placing what's called an extension blocker at that level, even if the patient is standing upright, that specific spinal segment does not extend as much as the rest do, and so there's still that symptomatic improvement that occurs in those patients who have spinal stenosis at that segment. Again, this is also a quick outpatient procedure that is performed by many pain physicians. Next slide. So this procedure was first FDA approved in 2005. As I mentioned, it's positioned between the spinous processes to provide indirect decompression by reducing lumbar extension. It preserves lateral and rotational movement. And then over the years, there have been several of these devices that have kind of come and gone. But there's one there's one device that still exists, and that's what really everyone uses when they're doing these posterior spinous process interspinous spacers. And so they can be used standalone or in conjunction with open decompression. Decreased complication rate compared to open decompression and or fusion. This is a cost-effective treatment as compared to continued epidural injections. And it can be placed using local anesthetic with sedation in an outpatient setting. So just a lot of numbing medicine, a little bit of anxiolysis medicine through the IV is more than enough often to be able to have patients tolerate this procedure just fine. So about 25 to 50% reduction in central canal and or lateral recess cross-sectional area compared to adjacent levels with at least one of the following. So these are the indications, right? So we're looking at central canal stenosis, right? And we're looking at nerve root impingement, fecal sac or spinal canal narrowing. We're looking at evidence of hypertrophic facets, and we're looking for a functional inability, incapacitation as well, right? So moderate impaired physical function defined as a score of greater than 2 on the Zurich claudication questionnaire, or ability to sit for more than 50 minutes without pain. Next slide. So most common contraindications for this are going to be greater than grade 1 spondylolisthesis, scoliosis with a Cobb angle greater than 10 degrees at that index level, severe osteoporosis, and again, remember you're putting this in between two bones, so if the patient has very brittle bones, it can actually cause the spinous processes to fracture, prior fusion or open decompression procedure at this index level, and then a BMI of greater than 40, of course, is a contraindication as well. Next slide. A lot of studies here that have looked at this procedure. So Wu and his team looked at, in 2014, systematic review and meta-analysis on these spacers compared to open decompression. And actually what they found was that there was no difference between interspinous spacers and decompression for back pain, for leg pain, for ODI, which is the Osteoarthritis Disability Index, or complications. They actually found that decompression had a lower incidence of reoperation. And their conclusion was that no difference in outcomes between open decompression and interspinous spacers, but interspinous spacers has a higher healthcare expenditure because patients need reoperation. Now, what I'll say about this is that, well, these are the findings of the study. This was looking at a specific device which is actually no longer on the market. And so I'm not quite sure that we could, generalize these findings to all interspinous spacers. In 2015, next one. Patel did a study as well, multi-center RCT, comparing two different spinous spacer devices in patients who had failed 6 months of conservative medical management. They looked at 391 patients, so a lot of patients. And they found that leg pain was improved by 77%. ODI improved at a minimum of 15% in 65% of patients. And the conclusion of this study was that both devices achieved clinical success, and one was not inferior to the other. And so again, both of them looking at interspinous spacers. Nunley did a study in 2017, which was a 5-year retrospective review, which found that 84% of patients who underwent interspinous spacer replacement reported improvement in their claudication questionnaire. 80% reported improvement in back and leg pain. 65% had a clinical improvement in Osteoarthritis Disability Index, and 75% had no reoperation at the index level at 5 years. For this reason, the MIST guidelines state that interspinous spacers should be considered for treatment of symptomatic spinal stenosis patients at the index level with mild to moderate spinal stenosis with less than or equal to grade 1 spondylolisthesis in the absence of dynamic instability or microinstability represented as fluid facets on advanced imaging. So again, a lot of words here. key thing that I want to illustrate to you guys is that this is an evidence-based procedure that is very helpful in patients who meet the criteria for it and who really have symptomatic spinal stenosis. Next slide. So interspinous fusion, this is a relatively newer device that was and procedure that was really developed within the past few years, maybe just in the past four or 5 years or so. And it's a device that rather than coming in from the back, actually comes in from the side, and rather than just being an extension blocker, actually has the ability to fuse that segment as well. And this is a procedure that's kind of come into the wheelhouse of most interventional pain physicians over the over the past 2 to 3 years at least. Next slide. So, this device actually came to the market to really address a pretty significant concern that existed for a lot of, both spine surgeons as well as advanced interventional pain physicians. And what they found was that traditional spine surgery, such as an open laminectomy or decompression, with or without pedicle screw fixation, so without those rods and screws that we often see in these patients, has really been the standard of care for spinal stenosis for decades, but this does have significant drawbacks, right? So extended recovery, chronic back pain from post-laminectomy syndrome, the risk of a CSF leak, nerve injury, hardware failure, altered spinal dynamics, which can lead to adjacent segment disease. All of these exist with the traditional surgical techniques that we have. And we're trying to figure out a solution for this. Next slide. So this leads to a gap in available treatment options for patients who are either poor surgical candidates due to their comorbidities, mild to moderate imaging findings, plus minus milder symptoms, recalcitrant injections. So these patients have some mild to moderate kind of findings on their imaging. Their symptoms are not super severe where they're like rushing to have surgery, but the injections just aren't helping as much anymore. And they have anatomy that prevents interspinous spacer replacement, right? And so this fusion device allows for minimally invasive treatment options with reduced procedural risks. Now, this procedure doesn't have, given the fact that it's still relatively new, doesn't have as much robust data behind it as some of the other ones do. But there is a 2016 study which was a comparison between unilateral laminotomy, which is a traditional spinal surgery, along with interspinous fusion device compared to bilateral laminotomy. And what it found was that the fusion group actually had a significant decrease in their disability index, and that the fusion group actually had a significantly increased or significantly lower bodily pain and improved physical function scores as well. Next slide. Dr. Fulowski, who's actually a good friend of mine and a spine surgeon out in Pennsylvania, also did a study and published it in 2022, which was a retrospective review of safety and efficacy of these interspinous fusion devices with 32 patients, and the patients had imaging consistent with degenerative lumbar spinal stenosis at 1 or 2 levels, significant reduction in VAS scores from 8.1 to 2.65 at 3-month follow-up, and there was no significant adverse effects at 90 days and no reoperation or revisions at that 90-day mark as well. For this reason, again, MIS guidelines consensus point 8 is that this is the treatment option which should be considered in patients who have less than a grade 2 spinal listhesis and have symptomatic spinal stenosis. Next slide. So spinal cord stimulation is an advanced pain treatment option which exists as well, and we often use it to treat intractable pain in the trunk or limbs. And so this is a device which delivers electrical impulses to the spinal cord, which modulates pain signals to the brain. The mechanism of action can be diverse, and it's really a function of the specific waveform of the electrical impulse, which is delivered by the pulse generator. This exists in this is a 2-step process. The trial portion, which is about a week long, and then the permanent implant as well. And while an approved treatment for lumbar spinal stenosis is really a positive data regarding the efficacy of this therapy, specifically for spinal stenosis. Next slide. So spinal stenosis is FDA approved in the US for the treatment of chronic intractable neuropathic pain of the trunk and extremities. The most common indications include failed back surgery syndrome, complex regional pain syndrome, lumbar radiculopathy, and painful diabetic neuropathy. Contraindications include uncontrolled psychiatric disorders, anticoagulation use, which cannot be paused, significant thoracic stenosis, which prohibits lead placement, and symptomatic infection as well. Next slide. So again, because this is a treatment which is not commonly used for lumbar spinal stenosis, there's not a great amount of evidence for whether or not this is a good treatment for it. In addition, it's just not a great treatment for it because we do have a lot of better tools now for directly treating the cause, right? That being said, it was a study in 2003, which was a retrospective review of 55 patients. 55 patients underwent a spinal cord stimulator trial, with 21 proceeding with permanent implant, and all these patients were being treated for their spinal stenosis, and they were not surgical candidates. 67% of patients reported greater than 50% relief of pain and improvement in function at 1.5-year follow-up, and 12 patients had a successful trial but opted to not proceed with the permanent implant. Next slide. There was a 2010 study, which was a retrospective case series of 69 patients, and what it found was that these patients who were treated with spinal cord stimulation for symptomatic back and leg pain for spinal stenosis, they did baseline data collection with median follow-up at 2 years. The baseline pain score was 7.4, 2-year follow-up baseline, 2-year follow-up pain score was 2.8, and they had a significant reduction, as you can see, in their oscillatory disability index as well. And for this reason, with a grade B in terms of recommendation for 15.11, MIST guidelines recommend that spinal cord stimulation can be used in the treatment of spinal stenosis after anatomic considerations at the index level of treatment for minimally invasive decompression options, and can be employed when more direct methods fail or are not suitable. And so, in conclusion, next slide. In conclusion, spinal stenosis is a prevalent and progressive degenerative process that results in pain and disability for many Americans greater than 50 years of age. While open spinal decompression and or fusion has long been standard of care, there existed a gap in treatment options for patients who were averse to invasive spine surgery, had mild or moderate symptoms or spinal pathology, or who were high-risk surgical candidates. These novel treatment options discussed today really present options for those patients. Next slide. Determining which treatment is appropriate for the patient starts with a focused history, evaluation of imaging, and physical examination. Best practices dictate a multidisciplinary approach to spine care is key, for which reasons patients should be referred to a spine surgeon for surgical consideration prior to proceeding with minimally invasive options. MIST guidelines provide a treatment algorithm, but patient care really should be personalized based on individual patient characteristics. So while these guidelines and algorithms are extremely helpful when we're treating patients, we got to always keep the patient-specific characteristics in mind. Next slide. This is the algorithm, which I'm happy to send to anyone who would like it. And of course, the MIST 2.0 guidelines are available online and readily available to everyone, free of charge. Next slide. And that said, any questions? Yeah, please.
What are like some lifestyle changes or like exercises that our patients can implement to help enhance the effects of some of these minimally invasive procedures?
Yeah. So the question is, what lifestyle modifications can be made either in the treatment of spinal stenosis or in patients who have already had these minimally invasive treatment options to help them get more bang for their buck, basically, with it? That's a great question. One, weight loss, right? So I think I counsel every patient, regardless of whether I'm going to do an invasive procedure on them or not, about the importance of lifestyle modification and about weight loss specifically in order to really get these patients to take as much load off of their spines as possible. That's one. Two is I often implement physical therapy for these patients, especially at the 4 to 6 week mark after some of these treatment options, because by that point their pain is actually a little bit better and they can have an improvement in their functional capacity as well with physical therapy, and they can really capitalize on those gains. Lastly, I've had a few patients kind of ask me about these dietary modifications with like a lot of talk these days about inflammatory foods and things like that. I haven't been able to find any, concrete study that really tells me that avoiding quote unquote inflammatory foods is important for spinal stenosis. But what I'll say is that, common sense is common sense, and really we should try to eat as much wholesome food as possible. And you don't need some, PhD telling you that food is inflammatory to know that it's inflammatory. Junk food probably is not good for us. It does contribute to overall morbidity as well. Great question. Any other questions? No? Okay. Well, thanks everyone for coming by. I really appreciate it. And thanks for having me at Chicago.